My name is Imelda Nhleko and I'm the Customer Success Champion. Today we celebrate 100,000 credentials and more.
Hi, my name is Lungabantanzima and I'm the graphic designer for Clinical Care Platform.
Hi everyone, my name is Kibita Mansahagwen and I'm the General Manager for Clinical Care Platform.
Hi, my name is Ria and this is the face behind Finance.
Hi, I'm Bolelo and I'm the Creative Manager here at Clinical Care Platform.
Colleagues, as always, just to say thank you very much for joining us this morning. It's a celebration.
Yeah.
We are so excited to celebrate this incredible milestone with you. Every credential represents an improved care for so many patients on a daily basis. There is a lot of health professionals here to join us every evening and are committed to excellence. This is not possible without you. So I really want to send a warmest congratulations and gratitude to every single specialist, every single health worker, every single non-health worker who has presented, who has had the courage to come on the platform and say what I want to contribute to enable health workers to do great things. So I want to appreciate Dr. Ryan Swepesat, Dr. Billy Magagula. Advocate Maud says she wants a t-shirt. What's a t-shirt? And Dr. Mkwanasi, for Dr. Lizelle Brown, and many more who continue to come and want to teach. I must thank myself. I do teach. If you have joined this session and you are not a member, now is that time.
Guys, and girls. Having sex without a condom does not cause the viral load to go up. So if you learn one thing tonight, please, having sex without a condom. Okay, this is anonymous. I don't know. Nobody knows who answered that having sex without a condom can cause a high viral load. But it's out there. It's not you. It's everyone. As you can see, 44% of you thought that having sex without a condom can cause a high viral load. All right. Please, it doesn't. Okay, the amount of virus that you get, if the patient's on ARVs and they've already suppressed, the amount of virus that you get with one act of sex will just be eaten up by the ARVs. It will not cause the viral load to go up. Okay, and I get this all the time. They phone my helpline and say, the viral load is 120,000, but don't worry about that. She's having sex with a condom. So I am worried about that because having sex with a condom is not going to do that. Some drugs have what we call a low barrier to resistance, a low genetic barrier to resistance. So if you imagine as resistance being a wall, and if you go over the wall, you get resistance. So that wall is very low, easy to go over. One mistake, one mutation, they get resistance. That's called a low genetic barrier. Others have got a high wall, a very high wall. It takes a long time to get over that wall. That's a high genetic barrier to resistance. So our approach differs according to which type of drugs and how long they've been. So these low genetic barrier ARVs, what are they? So 3TC, FTC, although it's not such a train smash because there are advantages to having resistant 3TC or FTC. The non-nucleosides, the viral interference or pivoring, has got low barriers to resistance. Integrase inhibitor are not dolutegravir, but raltegravir that used to have in old days, the low barrier.
Yay! Good evening, good evening, good evening, colleagues. It's just 1 minute after 6:30, and it's our time for learning and connecting, and committing to be better and better. I really, really want to really thank you for your ongoing commitment to growing every single day. Remember, if you would like tomorrow to be better, if tomorrow you want to be a better person, you have to commit to growth today. And as the clinical care platform, we offer that opportunity and help you to grow every single day and become better and better. All right. So we have to be consistent. Remember, great results take time to show up. And that means you have to keep going. You have to be here every evening and get empowered. So, yeah, thank you. Thank you very much for joining us. We really, really want to appreciate you for that. As always, I'm never alone. Hi, Dr. Leon. Can you hear me? Okay, he's here, but I think he
No, I
will.
can't hear you, but yeah.
Thank you. Thank you for not hearing me, Dr. Leon, and a warm welcome to you.
Thank you.
Colleagues, let me run down through my couple of slides just as an introduction. Just give me a few seconds to get I have a lot of screens here because we are also practicing new things here at CCP as always. All right, so tonight is the seminars in HIV management, and we are focusing on managing a high viral load. Remember last month we dealt with second line ART regimens. So today we are going to move swiftly and really focus on third line regimens, and we really want to leave you empowered. This session is strongly aligned with our mission to improve patient care, and we hope that you make this opportunity to learn, to practice tomorrow, and also, share with more and more health workers so that every single patient has a fair chance of being taken care of. We continue to celebrate having issued over 100,000 CPD credentials to yourselves, our members, but it's not possible without you, but also our collaborators, especially our instructors like Dr. Leon Levin. We are a membership-based platform. All our evening events are open access. You can attend as many as you would love to. However, for CPDs and other things, only subscribing paying members are eligible for that. If you are not yet a member of the platform, visit our website, www.clinicalcareplatform. Explore if there's alignment between our values and your value for growing daily and getting better and better. If there's alignment, join us on this incredible journey. Just to say that we still have some delays in the approval of some of the CPD sessions so that they can appear on your profile, but I think that the gap has been closed significantly. I think we are left with a handful of April sort of webinars, so the HPCCA is really catching up. Maybe it's because of the end of the month deadline. So yeah, do send us an email if you have any concerns, but we want to reassure you that we are on it and we communicate with them on a daily basis. Just to say as well, June is a busy month for us. We have at least 4 masterclasses on the 7th of June, which is this Saturday. If you are a member of this platform, you are invited to join us for the risk assessment smart skill. So yeah, I'll share the links and then just register your interest. Tomorrow you'll get your Zoom registrations and you can join us. There's no payment associated with this event. However, the last 3, the HIV resistance workshop with Dr. Leon, the masterclass on dermatitis, and also the Master Your FCP Part 2 focusing on pulmonology. These are paid masterclasses on a Saturday. Do visit our website and check them out. And yes, this is what's happening this Saturday. Say happening right now. Are there any members here? If you are here, just say hi with a heart or a thumbs up to say yay. And I'm so happy that I'm not alone. So I really, really look forward to connecting with you on Saturday. As we started with project management the last 2 months, and we are now starting risk management. And I can tell you there's more coming your way in this space. And yes, please, colleagues, Don't miss this Resistance Made Easy workshop. You are going to learn everything about HIV, responding to high viral loads, interpretation of mutations, using the Stanford database practically. This session is available both in person but also as a live virtual event. So when you register, you would have to select whether you'll be around Joburg to attend in person or you're going to be attending live. Actually, I have a link. Yes, so that is the link I've just shared there. It's a 6-point workshop, and it will be me and Dr. Leon and Dr. Viana there. So yeah, we are looking forward to hosting you. All right, so getting back to tonight's webinar, we really want to appreciate our collaboration with AbbVie for bringing this particular webinar to yourselves. And yeah, we are discussing management of a high viral load. It's a build up from the session we had last month. Today, we are focusing mainly on third line. And we have, our pediatrician, our HIV clinician, Dr. Leon, who's got lots and lots of years managing children and adults, because these children do grow. They don't remain kids forever, living with HIV. But personally, I've had a lot of coaching in my early days in rural Mpumalanga from Dr. Leon. So it's someone that I really, really appreciate. Dr. Leon, can I hand over to you to take us through tonight's session? Welcome, Doc.
You certainly can. Thank you, Dr. Lesejo. Let me just find my slides.
Awesome.
Welcome to everybody.
Welcome, colleagues.
Okay. Hopefully you can see full presentation view. Okay, great. Okay, good. Good evening, everybody. As Dr. Lesejo said, we did tackle second line regimens last time. So I'm going to touch on very, very briefly, but we're going to spend the bulk of the time on third line regimens because they are quite complicated, and they're not that complicated if you've got direction. So hopefully I'm going to give you some direction tonight. Once again, I really enjoy people asking questions as we go. So don't wait till the end to ask your questions. Just type in the Q&A. Sometimes I can even answer them as I'm going, which makes it much easier. It goes with the flow. If there's more difficult questions or that don't fit in with where we are in the talk, we can leave them till the end. But just type them all in the Q&A. Am I correct? The chat, don't type in the chat. The chat is just for saying good evening. And then
Yes.
we'll type in the Q&A.
Awesome.
All right, great. Good. I think let's start and just my disclosures and disclaimers here. And just to thank our sponsors for this evening, AbbVie and Dr. Mawela for the wonderful work that he's doing. I mean, you guys are witnessing, you're part of history because I mean, what he's creating is history. There's no question. And I also want to thank Dr. Ruth Lancaster, who's from the National Third Line Committee, who's given some input into this to make sure that my talk aligns with what the Third Line Committee is doing. Okay. So previously, it was very easy. We had first line, we had second line, and we had third line. Remember, TE, AZG3 lipinavir, horrible regimen, but what's what we had. And then third line was usually TLD plus darunavir. Sometimes we added etraverin to it. Okay, that was relatively straightforward and easy. Now, we've just got a mishmash. Okay, it's just TLD, 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 TLD1, TLD2, TLD3. So it's a lot more confusing. But there definitely is a place for TLD in all three regimens. And so it's important that you know where the place is. And I'm going to hopefully show the place of TLD in third line, but also that we label these accurately. Okay, that you label the patients TLD1, TLD2, or TLD3 so that we know for the future, if you see a patient on TLD in a clinic, you don't assume they're on first line. Okay, they could be on second line or they could be on third line. And obviously your management is going to be different. So you need to know that. So in terms of our third line committee, the definition of third line is any patient who's got protease inhibitor resistance or integrase resistance, so dolutegravir in our setting. Okay, and obviously other definitions, but in terms of the way things work in South Africa, that's what it is. If they've got PR resistance or integrase resistance, they are a third line patient. Okay, I want to give you a little bit of background on the third line drugs that perhaps ARVs that you're not that familiar with. And I'm going to be throwing the names around now. So you should just, I'll just give you a little bit of background. First, I want to talk about raltegravir. So raltegravir, okay, is like dolutegravir. It's an integrase inhibitor. It's a bit older. But unlike dolutegravir, which has got a high barrier to resistance. Remember, it's a high wall to climb to get resistance. Raltegravir has got a low wall, becomes resistant very easily. But unfortunately, if you get resistance to raltegravir, you can go on to develop resistance to dolutegravir. So it's not a great idea. In addition, raltegravir is twice daily, 400 milligrams twice a day. So it's much more difficult regimen to take. So really, we want to avoid raltegravir at all costs. And if you've got a patient that is on raltegravir, you want to try and get them off their raltegravir. But how you get them off depends on the virus suppressed or not. So you need to discuss with an expert. So you can't just, if the virus is suppressed and it's always been suppressed, you could just take them off raltegravir and substitute for dolutegravir for it. If the virus is not suppressed, you need to discuss with an expert because you may even need to do resistance testing to see if there is raltegravir resistance or not. Okay, so you want to get them off their raltegravir, but discuss with an expert how you do it. I'm going to show you this graph a few times tonight, and it's a lovely graph. So on the y-axis shows the potency, right? How many logs will it drop the viral load? So the higher it is, the more potent the drug is. On the x-axis tells you the barrier to resistance. How many mutations are needed to get high-level resistance? So now you can see raltegravir is over here, about 1.5 mutations. It's quite a potent drug, 3 drops the viral load by 3 log, but needs 1.5 mutations. Unlike dolutegravir, you can see is up here 3 mutations to develop resistance. Okay, darunavir is even better. Okay, so that's what I said is raltegravir has got a low genetic barrier to resistance, so you don't want to use resistant very easily, and that unfortunately causes cross resistance to dolutegravir, and we don't want to lose our wonderful dolutegravir. Next one I want to talk about is etravirine. Okay, you may not have heard much about it. It's on its way out, I would say. It's a non-nucleoside, just like efavirenz, but it's a second generation. It's more potent, and it will work even though there may be some resistance to efavirenz and nevirapine. It's got a higher genetic barrier than efavirenz or nevirapine, but it's a big pill burden. In our setting, it's going to be 4 tablets a day, 2 in the morning, 2 at night time. You can actually give it once a day. It's still going to be 4 tablets a day. And the other thing is that it's on its way out, I would say, if the patient is not on a non-nucleoside, you don't actually know if they've got resistance to etravirine or not. Okay, and we don't normally do resistance testing on patients who are on a non-nucleoside in the old first line. So by the time they get to third line, you do resistance testing. It says susceptible to etravirine. You don't know if it's true or not. So you may be giving this a big pill burden drug for an indication where it actually doesn't work because there's resistance to it. Okay. And in fact, also what's happened is that over the years, we've discovered that the other third line drugs, TLD and darunavir, is so potent that you virtually never need etravirine anymore. And it's really been sort of slowly disappearing. And once again, if you've got a patient on third line who's got etravirine, question that with an expert. Do you really need to have this patient on etravirine, or can you get rid of it? Okay, the one that we're going to talk about a lot, and one which you all should know about, is darunavir. Okay, it's a protease inhibitor. You always want to boost it with ritonavir, so darunavir. Very potent protease inhibitor, very high barrier to resistance. I showed you where it was earlier. There it is, right on top. So it's the most potent. You can see drops the viral load by 3 log, but the highest genetic barrier to resistance as well. So it's our most powerful drug that we have at this point in time. Okay, it's very high barrier to resistance. Now the dosing is interesting. I need to take you through this dosing. When it first came out, the dose was 600 milligrams twice a day plus ritonavir 100 milligrams twice a day as a booster. Okay, but then they discovered that in certain situations, you could use it once a day, but in a different dose. And in fact, in 2018, the Clinician Society came out with this guidance, appropriate use, clinical use of darunavir 800 milligrams. And in it, they said that if a patient, okay, is starting third line, so they've got PR resistance, but their Darunava score is 0, meaning there's no resistance to Darunava. They may have resistance to lopinavir, may have resistance to atazanavir, but there's no resistance to Darunava. Then you can give the Darunava once daily in a dose of 800, 100 once a day. Okay, in fact, we have a fixed dose combination that's available. Well, we've got a bit of a stock out at the moment, but supposed to be available. Of 400, it's called 400 stroke 50. So 400 milligrams of Darunava, 50 milligrams of Tonava, and you give 2 of them together, that gives you 800, 100 once a day. Okay, so if there's no Darunava resistance, you can give Darunava 800 to 100 once a day. So 2 of the 400 stroke 50 tablets once a day. If there is resistance, then you've got to give it, and then if there is Darunava resistance, then the dose of Darunava is 600 to 100 twice a day, BD. Okay, so this notice came out, said if the patient is starting third line and the Darunava score is 0, you can give it once daily, 800, 100 once a day. Or if they're already on third line with an undetectable viral load, and the Darunava score, the original Darunava score that was done at the beginning, resistance testing showed no resistance to Darunava, you can switch them from the 600, 100 twice a day to the 800, 100 once a day. Okay. So that's just in terms of the dosing. There are things that you can do. It's not such a train smash. If you've got a stock out of the Darunava 600, you could use 800, 100 twice a day. We've been doing that, no problem. The only problem is now we've got stock outs of both. It's not such a big difference in dose, but strictly speaking, if it's once a day, it's 800, 100 once a day. And if it's twice a day, it's going to be 600 milligrams once a day, together with 100 milligrams of ritonavir twice a day if it's the Darunava is twice a day, or once a day if the Darunava is once a day. Okay, so the dosing, just to summarize that, if there's no Darunava mutations, no resistance to Darunava, you can give it 800 milligrams of Darunava, 100 milligrams of ritonavir once a day. If there is Darunava resistance, then you would get that's 100 milligrams of Darunava and 100 milligrams of ritonavir twice a day. In some countries that we don't have an 800 or the 400 milligrams, what you could do is you could use a 600 milligram, 1.5 of the 600 milligrams, gives you 900, it's close enough, and you could do it once a day like that. That also would work fine. It's not a massive overdose. Okay, so I'm quickly going to touch on our new 2023 guidelines for a reason, because I want to show you that the same principles that we use in our 2023 guidelines are the same principles we use in our third line patients. Okay, so I'm going to quickly touch. I'm going to mention the second line regimen, but very quickly to show you the principles. So the principles of the third line of this new, or not so new, more 2023 guidelines are, number one, based on the Nadia trial. And we said the Nadia trial showed in patients who are failing tenofovir 3TC non-nucleoside regimen like TEE, if you change him to TLD, you know, changing one drug in that regimen, it's superior to AZT 3TC dolutegravir, which has got 2 new drugs. Okay, so this is Nadia. I'm sure you've heard about now, and that's what this guideline is based on. And there are 3 other trials which show the same thing. Okay, we don't know if the same applies to pediatrics, and that I'll touch on that later on. So can you go from a back of a 3TC non-nucleoside to a back of a 3TC dolutegravir? Will it behave the same as TE to TLD? We actually don't think so. But at the moment, we don't have any alternatives. Okay. So the principles of these new guidelines in 2023 are, number one, Nadia trial, meaning if you've got a TE regimen, you change to TLD. Or if you've got a dolutegravir regimen, a AZT3 dolutegravir, you change to TLD. That's Nadia. And the second principle is, if you make a mess of Nadia, have you got a backup plan? So in other words, let's say you put them onto TLD and you made a mess, and 6 months later they are failing. Have you got a backup plan? Okay, so if it's a non-Nadia switch, ensure you've got a viable, future, robust regimen. Obviously, we're talking usually a PR regimen, and if you have a PR regimen, then you can take a chance on TLD, okay? You can take a chance on TLD, knowing that if you make a mess, it's going to be not a problem because you've got a backup. Okay, thank you, Paul. We will get to that. Very important point that Paul's made, that darunavir cannot be used with rifampicin. Okay, you need to make a plan. Okay, and the plans usually that we would make would be to use rifabutin if possible. Otherwise, if you can't use rifabutin, then to use a non-rifamycin containing regimen, which is a longer regimen, but we do it fairly often in pediatrics where we struggle with rifabutin. So very good point, Paul. Okay. Someone asked about what about bictegravir? Bictegravir. So bictegravir, to all intents and purposes, is very similar to dolutegravir. It was developed because people wanted to have tenofovir together with dolutegravir, but unfortunately it was a different company made it. So the fixed dose combination of the dolutegravir was a backup initially was a backup 3TC and dolutegravir, and people wanted tenofovir 3TC dolutegravir. So bictegravir was developed, which is very similar to dolutegravir, so that you could have tenofovir or TEF, which is still tenofovir, FTC, and bictegravir together. So bictegravir very similar to dolutegravir. Okay, so based on the principles which we said were either NADIA, TE to TLD, or ensuring that there is a viable backup PR regimen. So let's look how these guidelines apply here. So in this case, all these TE or these Fabrin's regimens, okay, switching to TLD, that is NADIA, okay? Obviously, we can't use TLD, you'd use a backup with dolutegravir. Right, AZD3 dolutegravir to TLD, that's NADIA. Very straightforward, okay? Then what about this one? The PR regimen for less than 2 years. We know it's under 2 years, there's no resistance yet in the PI. So the PI is still active. So the PI is active. So we've got a backup PI regimen. We can go to TLD. So that's our second principle, saying if you take a chance on TLD and you make a mess, will there be a PI to back you up? Yes, there will, because there's no PI resistance. Okay, looking at that principle again, they're on a PI now for more than 2 years. There could be resistance, but the viral load is less than 1,000. Well, it's less than 1,000, you've got a suppressed viral load, so to speak. So it means the PR regimen is working. So you've got a backup PR regimen. So that principle also applies. Right. Then in a situation when they've been for more than 2 years and high viral load above 1,000, there could be resistance, and that's where the guidelines would then address whether we do resistance testing or not. So that's using those principles, showing how those principles apply to our guidelines. Right. Now, as we said, NADIA, try to get a TLD. If you can't do NADIA, then ensure that there is a backup PR regimen. So let's talk about our third line regimens, and then I'll bring in how these same principles apply to third line as well. So the third line committee is run by Dr. Ruth Lancaster, who does a fantastic job. That is her email address. And as we mentioned, the committee will only authorize third line drugs where there is PR resistance or integrase resistance. Now, I must say that the Western Cape, KZN, and the Free State also have their own provincial third line committees. I'm actually involved in both the national and in the Free State committees as well. Okay, so now the third line committee has come up with an algorithm, right? Just like AI, artificial intelligence, we think it's so smart, but it's just been given algorithms, right? This is what it's got to do, and it follows those algorithms. It's the same thing here. Follow the algorithm, and it tells you how to deal with third line. So why do we need an algorithm? Why can't we just do a thumb suck? I feel like giving this regimen today. I feel like giving this regimen today. Okay, so we want to have consistency. Remember, we've got a national committee and we've got 3 provincial committees. You don't want the provincial committee doing this and the national committee doing this. You want them all to do the same thing, because people move around. People move provinces, very easily, and they're going to go somewhere else. Oh no, that's not our regimen. It's going to cause confusion. You want to get consistency in the same committee. Even with the committee, I can tell you now, someone wants to do this, someone wants to do that. Okay, we've got a uniformity, we've got an algorithm that we all follow, makes life much simpler. Of course, there are exceptions. There always are. But as a guide, we are using this algorithm. You want to have transparency. We had complaints from people before we developed the original algorithm. You know, how come I've got one patient who's on this regimen and someone else is on a different regimen? You're quite entitled to question why. So at least you've got transparency. You can look at the algorithm and say, yes, this patient on this, that's quite correct. They should get that. Or wait a minute, this patient should be on this and they've done this. Why aren't they doing it? Let me question them. And 100%. So there's transparency. People can check that the third line committee is doing the correct thing. And if not, to question them. And we welcome people questioning us. Okay, so our previous third line algorithm that we had, it worked pretty well, I must say. It had its downside. The principles behind that algorithm was the more resistance, the more AOVs you need, which makes sense. Okay, so the options included 2 NRTIs plus darunavir. In those days, it was twice daily. After 2018, we would start using it once daily, but before that, twice daily. That was the first option. Then next option was 2 NRTIs plus dolutegravir plus darunavir. So you're adding in dolutegravir as well. And the third option would be a full house, would be 2 NRTIs plus dolutegravir plus darunavir plus etravirine. So the more resistance there was, the more drugs we gave them. And this was basically the adult committee. The algorithm, the pediatric one was very similar. I haven't put it in. It's just the same principles. So you had to have at least low-level resistance to either lopinavir or atazanavir, and everybody got darunavir plus ritonavir. And then together with 2 NRTIs, which was 3TC or FTC, plus either tenofovir or AZT, whichever had the least resistance. Okay, so in some patients that would be good, but if there was intermediate resistance or worse to tenofovir or AZT, or low-level resistance to darunavir or worse, then you would add in dolutegravir. Okay, but if you had not just the one or other, but both, you had intermediate resistance or worse to TDF or AZT and resistance to darunavir as well, then you'd add in etravirine. So you'd have 2 nukes plus darunavir, ritonavir plus dolutegravir plus etravirine. Okay, so the more resistance there was, the more drugs you get. And it actually worked, believe it or not. Okay, this was a paper which was published right in the beginning of the third line committee. I can't remember if it was 2015, somewhere that 2018, sorry, 2018, where we were still using raltegravir. We didn't have dolutegravir yet. Okay, and in this they showed those patients who'd had at least one viral load after 6 months, 83% had a viral load below 1,000 copies per mol, and 79% had a viral load below 400 copies per mol. So pretty good for third line patients. Okay, worked pretty well, but the big downside was a big pill burden. Okay, there were massive pill burdens, 10, 12 tablets a day, pediatrics sometimes even more. So you really had to take it. And remember, people who get to third line don't just waltz into third line. You've got to earn your third line, and usually you earn your third line by not taking your ARVs. So these are people with a history of adherence issues now being given this massive pill burden, and yet it seemed to work. Okay, but there will be cases where it won't work because of the massive pill burden. All right, so this is the mutation scoring for the Stanford database. We're going to deal with it in detail on the public holiday, the 16th of June, where we do have our masterclass, resistance workshop masterclass. But in this algorithm, we do talk about the scores. So I'm just going to mention what the scores are. So above 60 would be high level resistance. Between 10 and 59 would be resistance. Okay, and below 9 is susceptible or hypersusceptible. Okay, so just so you're aware, if I talk about above 60, that's a high level resistance. 10 to 59 would be either potential low level, or intermediate resistance, and then below 9 would be where the drug will work. Okay, right. So the principles of this new algorithm. Now remember what I told you about the principles of our guidelines. What are the principles of the guidelines? NADIA, use TLD where you can. And the second principle is if you're using TLD and you're not based on the NADIA study, if you're using TLD, make sure you've got a backup PI regimen. So what are the principles of the third line algorithm? TLD where you can, okay? As long as you've got a backup PI regimen, okay? So we can use TLD knowing it may not work, we may be making a big mess, but doesn't matter. Why? Because we've got a backup PR regimen. Same principle, isn't it amazing? Same principle. TLD where we can, because the principles of this new guidelines get as many people as possible to TLD. So even in third line, put them on TLD. You can, as long as you've got a backup PR regimen. So how does it work? Okay, and then obviously in the in the normal guidelines, first line, second line, that PR regimen would be atazanavir ritonavir or lopinavir ritonavir. But for the third line regimen, of course, your PR is going to be darunavir ritonavir. That's going to be the only difference. So this is the rationale. If darunavir is fully susceptible, in other words, the Stanford score is less than 10, then they get TLD, tenofovir, lamivudine, and dolutegravir. Right? Why? Because if the darunavir score is fully susceptible, we've got a backup darunavir regimen. It's working. And not only is it working, but we could use it once daily. So that means if you use your TLD and you make a mess and the patient fails that, and you need to give them a fourth line regimen, what have you got? You can give them tenofovir, emtricitabine, which is 1 tablet, darunavir, ritonavir, 800, 100, 2 tablets, 200, 400, 50. 3 tablets once a day for fourth line. So that's amazing, right? Amazing that you can have, you're using TLD as third line, knowing that if you make a mess, you've got a beautiful 3 tablet once a day backup fourth line regimen. Why not do it? Why not do it? Make their life simple. Give them a lovely 1 tablet a day. And if you make a mess, you've got a lovely regimen that you can use. Okay, 3 tablets once a day. So that's why if the darunavir is fully susceptible, we go for TLD. But now what if the darunavir score is 10 to 59? Meaning there is darunavir resistance. It's not so straightforward anymore because now you don't necessarily have a backup PR regimen because there's resistance to darunavir. So there what the guideline says, you know what? In this situation, you don't have a backup. What do? You kill this virus properly this time because you can't take a chance on the next line regimen because there isn't a next line regimen. And that's why we give them all we've got. The darunavir score is 10 to 59. We're going to give them TLD plus darunavir 600, 100 twice a day. Why? Because there's darunavir resistance, you give darunavir twice a day. So if the darunavir score is less than 10, you give TLD because you've got a backup. If the darunavir score is 10 to 59, you don't have a backup. So there you hit them hard because you want this regimen to work forever. So you give them TLD plus darunavir, ritonavir, 600 to 100 twice a day. Okay. If the darunavir score is above 60, there you've got high level resistance to darunavir. Now you're in trouble. Okay, this patient is in trouble. So there's an individualized regimen, and we will touch on that. Okay, so the principles, aren't they beautiful, right? Anyone who thinks they're beautiful, give me a thumbs up. Beautiful principles, okay? If darunavir is susceptible, score is less than 10, TLD. Why? Because you've got a backup PR regimen because it's telling you darunavir will work. Fantastic, okay? If the darunavir score is 10 to 59, meaning there's darunavir resistance, you haven't got a backup, so you hit them with all you've got. TLD plus twice daily darunavir, ritonavir. If the darunavir score is above 60, you're in trouble, individualized regimen. Okay, so fantastic. Same principles that we use for the guidelines applying to third line. And this is what it looks like. I must actually see if I can find one maybe in the end and I'll put it on the people can copy it. Otherwise, Lesecha, if you do have one available, you can paste it in the chat. But I should have one. I'll find it to put in as well. Okay, so this is the algorithm, and I'm going to take you through it step by step. So let's do number 1 and number 2 together. I've put them together because they both are darunavir resistance where the patient has not been on a protease inhibitor. Okay, so the first one is the first line darunavir regimen, which you know is going to be very unusual, that people, TLD1 are going to get resistance, but it does happen, and we are seeing it. Okay, and the second line with a second line TLD2, but they've never had a PR before. So in other words, they were maybe on efavirenz before, okay, and now they are went on to TLD, and they're failing. They've got resistance to TLD. Sorry, I just want to just. Good. Okay. So you understand the question. Patients who are on a dolutegravir regimen, they've never been on a protease inhibitor before, and now they've got documented dolutegravir resistance. So what do we do in those patients? So there's no PI resistance. So there's no PI resistance. You can give them a PI. Which PI do we give them? So our guidelines say darunavir and once daily. Why? Because there's no darunavir resistance. They've never been on a PI. They can get once daily. So they can get 2 nucleosides plus darunavir. The debate is why darunavir, why not atazanavir, why not lopinavir? Okay, so once again, going to this graph which I showed you, where we said darunavir is right there on top. It's the most potent PI, most potent drug we have. Okay, it has the highest genetic beta resistance. It's of the PIs, the best tolerated as well. So many reasons to rather go for broke. Patient is compromised by not having dolutegravir available to them. They've got dolutegravir resistance. They're compromised. We don't want to compromise them further. Okay. If we had to go for atazanavir, we are going for a low genetic barrier resistance drug, which can develop resistance and could even go on to develop darunavir resistance if we keep them long enough. We don't want that to happen. Lopinavir, we know is poorly tolerated. So that's why our guidelines say to go for darunavir, go for broke. The best possible regimen is going to be 2 tablets, because once a day, could be 400/50, 2 of those once a day, together with your nucleoside backbone. And we know from the Nadia study and from the Ernest study, you can use resistant NRTI, so go for tenofovir and tricytibine plus darunavir, 3 tablets once a day in this situation. Okay. So yeah, so patient who's on a dolutegravir regimen has got dolutegravir resistance, never had a PI, they can get a PI regimen. We said we're rather going to give them darunavir plus any NRTIs which will work because of the Ernest and Nadia trials. So you can give them tenofovir FTC plus once daily darunavir. Obviously, if they've got resistance, if they renal dysfunction or it's a pediatric patient, they can get a backup of 3TC plus once daily darunavir, going for once daily NRTI backbone to make life simpler. So we've gone for a very simple 3-tablet once a day regimen in a 3rd-line patient, and that's what it says in the algorithm. But I'll just paraphrase it in my slide. Okay, right. So that's dolutegravir resistance, where they've never had a PI before. There's no PI resistance. They can go to darunavir plus 2 NRTIs. Right, now let's look at patients who have got PI resistance. So they've got a PI score above 15. And we've split it, number 3 and number 4, depends on the degree of PI resistance. Okay, the degree of darunavir resistance. So they've got PI resistance, yes, but we now look at darunavir resistance, like we mentioned earlier. Because if the darunavir score is less than 10, means darunavir, they're still susceptible to darunavir. So we've got a backup PI, we can go TLD. If the darunavir score is 10 to 59, there's no backup PI because there's resistance to darunavir. There we have to hit them hard. So let's look at those in detail. So number 3, you've got PI resistance, but no darunavir resistance. The score is less than 10. So because the score is less than 10, because there's no darunavir resistance, we've got our backup regimen of a PI of darunavir plus 2 NRTIs for the future. We can save that for the future and take a chance on TLD. Okay, or obviously if they're not eligible for TLD, they can get ALD, or hopefully when the new tender comes out, or in private patients, they can get TAF Ed or TAF LD. TAF you can use in this situation with the creatinine clearance above 30. So if the creatinine clearance is above 30, you can use ALD or you can use TAF-Ed or TAF-LD. Okay, TAF-LD and TAF-Ed is just like TLD, but using TAF, which is safer on the kidneys. Okay, so to summarize this one, if the darunavir score is less than 10, meaning there's no resistance to darunavir, you've got a backup PR darunavir regimen, so you can use TLD, or if you can't use TLD, if there's renal dysfunction or pediatric patient, ALD or TAF-Ed or TAF-LD. And knowing that if you make a mess, if you get resistance to that, you've got a beautiful backup PR regimen, once a day PR regimen. They do mention, I'm not 100% sure why they say this, but if there's unknown PI exposure in children, adolescents, or young adults, do an individualized regimen, because there is another category, category 7, which does deal with where you're not sure if there's PI resistance or not. And I think that could possibly fit in there as well, but that's okay. That's what it says. Okay, so we said there's PI resistance, score above 15, but there's no darunavir resistance. They can get TLD knowing you've got a backup darunavir regimen. If there is darunavir resistance, a score of 10 to 59, so there you can't rely on darunavir as a backup. So there you want to hit them hard. You can't use once daily darunavir because there's darunavir resistance. Remember, darunavir resistance, you've got to give darunavir 600 to 100 twice a day. Okay, so therefore we hit them hard with this regimen, TLD plus twice daily darunavir ritonavir, 600 100 BD. Okay, hitting them hard because there is no backup. There's nothing after this. So you want to hit them with the best we've got at this point in time. All right, so you can't do TLD on its own because you don't have a backup. So you hit in TLD plus twice daily darunavir ritonavir. So you're going to get the best possible chance. It is not the nicest of regimens. It's twice a day, but we don't have a backup, so we don't want to take a chance. If they're not eligible for TLD, then you would then use ALD plus BD darunavir ritonavir. And it does also say there that if there are adherence concerns and the darunavir score is less than 30, meaning there's just low level resistance to darunavir, you can consider TLD with expert advice. So the third line committee can have a look and say, you know what, this is a teenager struggling with adherence now. They're not going to manage it twice daily. The darunavir score is low level. We can use that as a backup. It's not going to be as nice as having a once a day regimen, but we have got a backup. So in that situation, yes, you could give them TLD, but discussion with an expert. And that's all in this algorithm. Okay, so that's all it is there. Remember, the last point, number C, discretion may be applied if the adherence concerned darunavir score is less than 30. In these cases, you can consider using TLD alone after discussion with the expert or the third line committee. Okay, so that's all in this document. Everything that I'm taking you through is all in this document. Okay, so now we spoke about the first 1 and 2 patients who have got dolutegravir resistance but never been on a PI. They will get darunavir ritonavir plus 2 nukes. Okay. The next one we dealt with was where there was PI resistance, and we divided into number 3 was if the darunavir resistance is less than 10, meaning no resistance to darunavir, there they get TLD because you've got a backup darunavir regimen. Okay, and the next category, number 4, was where there is mild low level to intermediate darunavir resistance. Okay, so there you don't have a backup, so there you would hit them hard with darunavir twice a day plus TLD. Okay, somebody's asked a question, a very good question. Any point of doing resistance to TDF or 3TC? Do they have any influence? Yeah, this is in terms of this algorithm. If you are looking at, and remember, if a patient is not on tenofovir, let's say they're on second line AZT, you may not see the resistance to tenofovir either. So it may not be that helpful. So you're quite right. The most important criteria for this algorithm is really the dolutegravir resistance and darunavir resistance. So you really don't need to do it. The problem is that the way that the lab's set up at the moment is that the NRTIs and the PIs go together. So you can't just ask for just the one. I know one of the private labs can do that. You can ask for just PI, but the NHLS is not. It all comes together. But you're right. If you want to save money, and the private labs do charge for, you can just do, if you just do PIs, they'll only charge you for the PIs. So if you want to, a patient can't afford to do the whole lot, in that situation, I would just do the PI resistance. And if it's a patient who's on dolutegravir, you want to know if they're failing dolutegravir, just do the dolutegravir resistance. So it's a very, very good point that you make there. Okay, so now the third situation where you've got PI resistance, but here your darunavir score is above 60, so you've got a high level resistance to darunavir. So you definitely don't have a backup Darunava regimen here. Definitely not. You've got high level resistance. But they've never had an integrase inhibitor. So dolutegravir will still work. What do you do in that situation? So we said, if I can get my slides to move, discuss with the third line committee. Okay. TLD could possibly work. Okay. But there's no backup if it fails. But I can tell you now that in the third line committee, sometimes we just say, you know what? We're stuck. We've got nothing but TLD. We know we don't have a backup regimen, but what can we do? We can't send this patient out on nothing. So we would then, in that situation, recommend TLD. There are other options which I'll talk about later on, but generally, that's often what the third line committee does do. But being aware that that patient now is in big trouble because if this TLD doesn't work, there's nothing else. They would need to try and access the newer drugs. Okay. And they do say if adherence concerns, you could try TLD. I must say that it seems to be the third line committee, we're doing it, the adult committee doing it more than just adherence concerns, but just because we don't have anything else after this. But alternatively, if you could come up with an individualized regimen, sometimes you can do, if you can get hold of tropism testing to see if Maraviroc would work, but the Maraviroc is very expensive and, you know, that's not readily available in the state either. But in private, maybe something that you could do. So this is what the algorithm says. They're on a second line PR regimen. They've got PR resistance, Darunava score greater than 60, never had an integrase, discretion may be applied. Okay, and you can consider using TLD alone of discussion with the third line committee. Right, now, what about patients who are already on third line and not what we would like to see here, but they are failing their third line regimen? What do you do in that situation? They're on third line already, it could be an old third line regimen. What do you do in that situation? Not something we want to see, but we do see it. So they may need to repeat resistance testing because remember, you know, you might have found that, you know, back in 2016, there was no Darunava resistance, but they've been on Darunava for 8 years now. Okay, there could definitely be Darunava resistance, so you'd want to repeat that. But remember, if they're non-adherent, resistance testing will show you nothing. So you need to get them to be adherent, and you know, like I like to do, give them 1 month to go forward, because no one's going to admit that I wasn't adherent before. So you give them 1 month to take it every day, so we can just get an accurate resistance test, and that then might be able to help us to fashion a new regimen. We obviously want to consult with the third line committee and an individualized regimen based on resistance testing and clinical history. So that's patients who are failing a third line regimen. I do touch on it later on as well when we talk about third line, patients on third line already. Okay. The next pattern we want to talk about, it's a patient who presents with dolutegravir resistance, but they've been on a PI before. And remember, the guidelines is a whole big category. Someone's on a PI for more than 2 years, but adherence is less than 80%, you switch them straight to TLD. Why? Because it's less likely you'll have resistance to the protease inhibitor. But it's not that there'll be zero resistance. Okay, it's not that there's going to be zero resistance. There could be resistance. And these are what this group is talking about. They've got dolutegravir resistance. We switched them to TLD, but they weren't a PR before, and we've got no clue if they've got PR resistance or not. Okay? And these are the ones I worry about because very often they have got PR resistance. So here, what the algorithm says, they may have PR resistance, we don't know. So we will give Darunava over 800, 100 once daily plus 2 NRTIs. Okay. But watching them very carefully, doing a 3-month viral load. Okay. And if the 3-month viral load is not suppressed and adherence is good, then you do a resistance test then to see what's going on. Because we didn't have this resistance test back then when we should have done it. Okay. 3 months is not going to compromise the PI. So it's not a problem to put them onto that regimen. I prefer, like it says, to use the once daily because it's going to be good for adherence. And then if they're not suppressing, you do resistance testing. And then based on that, you would then adjust the regimen. Okay. The algorithm does say that if the history suggests possible Darunava resistance, you could start with Darunava twice daily. You could do that. I must say I prefer not to because you adding in a more complex twice-a-day regimen. So they're going to fail it because they're not taking it, not because it's resistant. So I prefer to go for the once-a-day regimen for 3 months. And if they're not suppressing, do resistance tests, then you know exactly where you stand. But it is in the algorithm that if you strongly suspect durable resistance, you could use twice daily. I would caution against doing that. And of course, if they have got renal dysfunction or it's a child, then you would use abacavir 3-TC plus darunavir instead of tenofovir and tricytavir and darunavir. Okay, so that's point number 7. The patient's got dolutegravir resistance, but they've been on a PI before, but we don't know if they've got resistance or not because no resistance testing was done at the time of the switch to dolutegravir, which is a lot of patients in our guidelines. Okay, so that's the algorithm. It's pretty straightforward, right? We said the first category was patients who've got dolutegravir resistance but never been on a PI. There they get darunavir as 2 nucleosides. The second 2 would be so 3 and 4 would be talking about patients who've got PI resistance. 3 would be patients who've got darunavir scores less than 10. Darunavir is still active. You've got a backup darunavir, they can get TLD. If you've got a darunavir score between 10 and 59, they've got low level or intermediate resistance to darunavir. You don't have a backup, so you hit them hard with darunavir twice daily, plus 2 nucleosides or plus TLD. Okay. And then the next one was you've got darunavir score above 60, high level darunavir resistance. You definitely don't have a backup there. Okay. So they're individualized regimen. And then we spoke about point number 7, patients who have been on of patients failing a third-line regimen, there you would want to repeat the resistance testing after making sure they've got good adherence and then individualize the regimen. And then point number 7 is where they've got dolutegravir resistance, but they've been on a PI. We don't know if there's PI resistance or not. Then you try them on 2 nukes plus darunavir, preferably once daily, but repeat the viral load at 3 months. If they're not suppressing with good adherence, then repeat your resistance testing. Okay. So who should be using this algorithm? So like we said, members of all the different third-line committees to keep consistency. Pharmacists with patients on third-line regimens. If you're a pharma, I hope there's some pharmacists in the audience. Any pharmacists, please give us a thumbs up. I think they're the most neglected members of our team. Oh, good. Fantastic. Great. So pharmacists should have this there. So they've got a third-line regimen. Check that they're on the correct regimen. If not, question it. That's your job, to make sure that we are prescribing the correct drugs. Clinicians, patients with PI or dolutegravir resistance before applying for third line to see what the patient needs. Okay. But why would you want to do that? Why don't you just leave it to the third line committee to decide what the patient needs? Because what if you see that the patient needs TLD? You've got TLD in your clinic. Why can't you just give them TLD there and then? Okay. The algorithm says to use TLD. Why can't you say, Mom, so go to the third line committee. I've got it on the shelf. Here's your TLD. Off you go today. Okay. So this is the question. Can you change the patient's TLD without the third line committee authorizing it? You may think no. I asked Dr. Ruth Lancaster and she said yes. Okay. So if the algorithm says to use TLD, you can do that. You can put them onto TLD straight away, right? What are the advantages of this? Well, you don't have to wait to apply to third line for the third line committee to come back to you with an answer. The patient doesn't have to go home and come back. You can literally give them their medication today. You're also going to prevent the evolution of resistance. If you keep them in the PI, you're going to get more and more resistance developing. You don't want that. Okay. And also make their lives a pleasure. Put them on a nice 1 tablet a day sooner rather than waiting. So yes, you can do that. Okay. And TLD, we know, is available at all facilities. You can do that. But there's a big but. Do you still need to send in a form to the third line committee? So the answer is yes. You can change it to TLD on your own, but you still need to apply to third line. Why? Because the third line committee needs to know about these patients. They are circulating with resistance to PIs or dolutegravir. We need to know about these patients. Okay. In exceptional cases, the third line committee may say, yes, the algorithm says this, but we worried about this and this, and we'd rather put it into a different regimen. That could happen as well. Okay. And also for planning. We as a country need to know how many patients out there will need darunavir in the next year or 2 or 3 because they have got resistance and they're on a TLD at the moment, but if it fails, they're going to use darunavir. So from a planning point of view, we need to know about these patients. So yes, you can put them on TLD straight away, but you still need to fill in the form and send it off to the third line committee so that they are aware of those patients, so that they can plan for the future of how much darunavir we're going to need in the future, and also in exceptional cases, they may alter the regimen. Okay, so I think that's fair enough. Okay, you're very welcome. If you use the algorithm, put them on TLD if the algorithm says TLD, but remember still to send it off to the third line committee. Or if you phone on the helplines, often the helplines will help you, but you still need to fill in a third line committee application. A word of caution. Okay. Although these patients, as I mentioned, right, these patients now are going to be on TLD, but they're third line patients. They have got inside their bodies resistance mutations causing resistance to PIs, right? So, it's like walking time bombs out there. So you don't want them just circulating with all the other TLD people and thinking they're just like everyone else. They're going to be down referred, slip through the cracks, and we won't know who these patients are. So you've got to keep track of these patients. Very important to label them as TLD3. So in the file, TLD3, so if they are failing, you need to up-refer them, you need to consult with an expert. You don't just treat them as you would any other patient who's failing in the TLD regimen. Okay, so very important caution that I mentioned. Right, so what about patients who are already on third line? And we said the third line regimen in the old days were really complicated, horrible regimens. Do we just leave them? If it's not broken, don't fix it. Some people have that attitude, but other people feel, why not make their lives a pleasure? Especially if they're suppressed. If someone is suppressed, for 5 years, I'll show you a patient, 5 years on a horrible regimen, and they've got a suppressed viral, I want to reward them. Reward them by giving them a nice, simple regimen, not keep them on the same punishing regimen. Okay. So can we optimize their regimens? They're on third line. Can we optimize their regimens? And yes, we can. Because remember, there have been major changes and advances in third line regimens. We spoke about darunavir had to be given twice a day in the old days, 600, 100 twice a day. Now can be given once a day. Could they go on to once a day? So yes, you could. Sorry, I have some questions. I'll answer them after this slide. Okay. So you certainly could do it. Some patients are still on raltegravir. They shouldn't be. We said raltegravir's got a low barrier to resistance. You want to get them off, but there's still some patients on. It's twice a day. It's going to compromise their dolutegravir. Move away from raltegravir, but the correct way of doing it, discuss with an expert. Okay. As I said, we could go to once daily darunavir regimens. You could even change in certain situations to TLD. If they qualify for TLD according to the algorithm and they've been suppressed ever since, why not give them TLD? So you could do. So every patient on third line needs to be reviewed towards optimizing the regimen. And in fact, on my helpline, some people phone from certain hospitals. I won't mention. I'm very happy about those hospitals. They'll phone the whole 5 patients on a Monday morning, and we go through their 5 patients and we optimize their regimens. Or we set up, some hospitals have set up a meeting once a month where they bring their third line patients and we will just go through them and optimize their regimen. And phone our helpline and with welcome to, and we'll help you to optimize the regimen. So it's something, especially if they are suppressed. If they are suppressed, it's very simple to change around. If they're not suppressed, you also want to discuss with an expert because they're not suppressed, they're failing third line, you need to deal with it as well. So it doesn't matter whether they're suppressed or they're not suppressed, but suppressed is very easy because you can optimize. If they've been suppressed ever since, you know what the resistance is like from way back there, you can use the algorithm to adjust their regimen, discuss it with an expert, and make these patients' lives a pleasure. So there are a couple of questions that people have been asking. So let me just quickly go through that. The patient who has a very high viral load, is on TLD, can we add in dolutegravir even if they don't have TB? So that's an interesting question. It's from an anonymous person. I won't tell people's names, so you can, even if you're anonymous, you can say who you are, but it's fine. Patient's got a high viral load on TLD, can you add in dolutegravir? So if a patient has, I think what you are alluding to is, if a patient has been exposed to an integrase inhibitor before, or there's resistance to an integrase inhibitor, so they've been on raltegravir, and there's some resistance to raltegravir, but still susceptible to dolutegravir, then a dose of dolutegravir is going to be 50 milligrams twice a day. You would then give an extra dose of dolutegravir in that situation. But I think if a patient's just got a high viral load on TLD, I don't think people would just add in an extra dolutegravir, because remember, you're going to add in twice a day, you're going to just make the adherence worse. I think you need to follow the guidelines in terms of addressing adherence, depending on the amount of time they've been on, doing resistance testing, and if there's resistance testing, deal with it in the proper way, not just adding in an extra dolutegravir tablet. But it's a very good question. Are these principles same for children less than 10 years? Yes, they are. But obviously your regimens are different. We can't use tenofovir in children under 10. You can use TAF in children under 10, and TAF hopefully will be available from when the new tender kicks in November. And TAF, you can, TAF, we have a 25 milligram TAF, you can use from 25 kilos. There is a 50 milligram TAF available overseas where they can use it from 14 kilos, which we're looking forward to that, because that will obviously make life so much better for our young kiddies. But the principles are the same for children under 10 years. So very good questions, keep them coming. Okay, so we'd use patients on third line, especially they're suppressed, we'd use the third line algorithms together with an expert to optimize their regimens. Right, now, let me show you a patient that I had to deal with about a year or so ago. Real life patient. Somebody's asked, when do I add dolutegravir on top of TLD? So generally only if they've got TB treatment. Okay, generally only if they've got TB treatment, and you would then give a second dose of dolutegravir. But if it's a third line patient and we've decided to use dolutegravir again, and there is resistance to dolutegravir, then we would give a second dose of dolutegravir in that situation. But you wouldn't just add it in, you wouldn't just throw it in there. If you do a resistance test to analyze it through the Stanford database, which is what I'm showing you now, and there is dolutegravir resistance, it will say at the bottom there that this patient has intermediate resistance to dolutegravir. If dolutegravir is used, it should be used twice daily. Okay, but so that would be the situation. So either if there is TB, rifampicin, or remember some of the anti-epileptic drugs also, you would also use an extra dose of dolutegravir, or in this situation where there is either experience with an integrase inhibitor or resistance to integrase inhibitor, and you're still going to use the integrase inhibitor, then you would use it twice daily. Okay, and then somebody asked about doravirine. Doravirine is a new drug. It's a non-nucleoside. There may be some role in using it in third line. We don't have it at the moment, so it's not something that we would be using. But you need to be certain that it's actually going to work. And remember, most of our patients on a non-nucleoside, we don't do resistance testing while they're on the non-nucleoside, so you actually don't know if doravirine is going to work, just like with etravirine. So I suspect it's going to be fairly limited. Just as the etravirine is fairly limited in our setting. Okay, so this is the resistance of this patient. All right, so what do we see here? There is major PI mutations, a 46I and 88S, okay, and an accessory mutation. If we look at the Stanford database, so it says high level resistance to atazanavir, potential low level resistance to lopinavir, and susceptible to darunavir. And you look at the darunavir score, in fact, it's a -5. It's a hyper susceptible. Okay, so if this was a new patient coming in with PI resistance, all right, and it was susceptible to darunavir, that would be category number 3, which says darunavir score less than 10. What do we give them? TLD? If it was today, right? Let's look at the NRTIs. Well, there's a 62 AV, okay, that means the mixture. So 62A would be wild type, 62V is the mutation, all right? And there's a 65R and 184V. 62 is a mutation. We don't see that commonly. It goes together with the Q15N multi-NRTI complex. It's a secondary mutation that goes together with that, but on its own, it doesn't have much significance. Okay, so the NRTIs, you can see there is a backup resistance, there is 3TC and FTC resistance, tenofovir is intermediate, AZT is susceptible. Okay, so using today's algorithm, this patient will get TLD, but this was 2018. This patient was placed using the algorithm of the day, was placed onto AZT3TC, 1 tablet twice a day, raltegravir, 400 milligrams, 1 tablet twice a day, darunavir, 600 milligrams twice a day, ritonavir, 100 milligrams twice a day. Okay, and I've added in fluticasone there because fluticasone, remember, has interactions with darunavir, so you can't use it together because it's Cushing syndrome, so it also wasn't the best choice there. So looking at the ARVs, we have got 2, 4, 6, 8 tablets, a twice a day, 4-tablet twice a day regimen that this patient is on. Okay, and this patient has remained suppressed ever since. For 5 years, suppressed viral load, torture, 8 tablets a day. Okay, and I don't know if the patient was Cushingoid, but certainly fluticasone can. I don't think she was using the fluticasone that often, luckily. Okay. Cost for the medical aid, 3,200 Rand a month for this regimen. So what did I do? She's suppressed. I used our algorithm and I said, oh, this patient's got fully susceptible to darunavir. That's category 3. We can use TLD knowing that you've got a backup darunavir regimen. And based on this, we simplified to TLD once a day, approximately 250 Rand a month. Okay. And she remains suppressed ever since. And if she does have a viral load going up, we've got a backup once a day regimen. So this is, can you imagine this patient's face when I told her, instead of your 4 tablets twice a day, you can take 1 tablet a day. Okay. And this is a reward for the torture that she went through. It wasn't her fault. That was the regimen of the day. But why do we need to punish her? Okay. So very important. Patients who are suppressed on third line, every third line patient must be reassessed to either simplifying their regimen or sorting out their treatment failure. One or the other. But either way, you want to reassess every single third line patient. Okay, so we spoke about patients failing the third line regimen. I just want to mention it here again. You may need to repeat resistance testing after a month of good adherence, consult a third line committee, and an individual regimen based on resistance. Now, sometimes you might find that a patient has got no options left, okay, and then they need some of these new drugs that are available overseas, like lenacapavir or Postemza, whatever it is. And some of these are actually being trialed in South Africa. So you can actually get them onto a clinical trial. So it's worthwhile looking into. In fact, there's a pediatric trial at the moment of Postemza and lenacapavir as well. So you can do the adults. I don't know what they are, but ask around because it may be if the patient doesn't have any options available that you can do this. What I have also done is I've also done tropism testing in some of these patients. Don't want to go into too much detail, but tropism testing is used to see if a drug called Maraviroc would work, okay, depending on which cofactor the virus uses. If it's CXCL4, you can't use Maraviroc. If it's CCL5, you can use Maraviroc. And then in that situation, you could use Maraviroc as an extra drug as well. It's very expensive, but it is something that you can look into as well. So these patients failing third line regimens really need intensive investigations, discussion with experts. And so if there is a clinical trial out there, by all means, put them onto the clinical trial. Okay, right. Here's a very good question. The pharmacists are asking, can they order darunavir 450 if it's a fixed dose and you've got a patient on darunavir 600, 100 twice a day? Okay. Is there any problem? So if you give them 800, 100 twice a day, you can do that. We have been doing pretty regularly in the state where we've been had the stockouts of the 600 milligrams. You can do it. It's a slight. Darunavir, you can literally go up to 100% of the dose. If patients are resistant to Darunavir, one of the things we do is increase the Darunavir dose. In fact, I had one patient on my advanced clinic who, patient was from Zimbabwe, if I remember correctly, who we organized for them to come to South Africa to do a tropism test. But I said, in the meantime, let's just increase the Darunavir dose. And also there was dolutegravir resistance, so we increased the dolutegravir dose as well. The patient arrived in South Africa to do the tropism test. Viral load was suppressed just on increasing the Darunavir dose and the dolutegravir dose. So in that situation, that's something else that we can do as well. And you can go up to 100% of dose. So to go from 600 to 800 twice a day, no problem. So there's a stock out of 600s, or if the patient prefers a fixed dose combination, they don't want to, have to have the 600 and 100, although it's still going to be 2 tablets, you can give them 800, 100 using 2 of the 400/50 tablets. That's no problem. Very good question. Okay, that's not really relevant to this talk. Okay, great. Thanks for the question. Okay, so that's a patient who's failing a third-line regimen. So the reason why I've discussed it afterwards here is because, yes, the algorithm does mention some things, but also to remember clinical trials and also increasing doses, tropism testing. There are other things that can be done in these patients as well. They are very complicated patients, and they need definitely need to discuss with an expert. All right, pleasure. Okay, so to summarize, third-line patients, if you haven't realized it now, I think you do now, okay? They are complex. The vast majority, as I said, didn't waltz into third line. Must have had adherence issues to get there. They've earned their third line, okay? Not always. Some patients, in the old days got TB treatment and interactions, but in the vast majority, it was adherence issues. Traditionally, our third line regimens have been big pill burdens, difficult to take, making adherence worse. Okay, and if we can simplify our third line regimens, both in patients who are already on third line and our new patients going to third line, why not? Why not make life as simple as possible? As long as you don't compromise their future by making sure there's always a backup regimen if you're going to go TLD. Okay, so this new third line algorithm, as you saw, it simplifies regimens, but remember, it's only a guide. There's never a substitute for discussing it with an expert, with third line committee or an expert, to make your patient's life as simple as possible. Because yes, they are on third line. We've got this fantastic algorithm. It's really great. It really makes life so much simpler. It makes a lot of sense, but we're not putting our patients at risk. We are making sure that if you're going to go out on a limb, a TLD limb, that you've got a backup regimen. And that's fine. And that's perfect. Okay. But discuss with an expert, because it is a guide. And like with every guide, there are nuances to it, and it's worthwhile discussing with an expert. I put this in here. Sorry, Dr. Lesejo, I know you didn't mention already, just to mention that if you found this topic interesting and you want to go into a lot of detail, including that Stanford database, which I showed you, the patient, which I analyzed her resistance on that Stanford database. We will be doing it. It's on a public holiday, so you don't have to take off work. You do have to take off public holiday, unfortunately, but you're welcome to join us. And it's a hybrid. It's both in person in Johannesburg or on Zoom, and just contact Dr. Lesejo. I think he did put it on the chat. I think he maybe put it on again if you want to, if you're interested in joining that. And just to remember the helpline, I will type it into the chat. If you do have any questions you want to ask, you're welcome to give me a call. We have got a helpline. It used to be the Right to Care helpline, but since Right to Care is no longer functional, or the Right to Care helpline is no longer functional, we've continued it, and we're just calling it the HIV expert helpline. We're busy looking for funding for it, but you're welcome to call, and I'll type the number in below here. All right, Dr. Lesejo.
Awesome, colleagues. What an awesome session, Dr. Leon. As always, I really, really want to appreciate your time to empower us. You know, I always say it's such a complex topic, but whenever you teach it, you know, it just flows and it gives us a lot of confidence. I also believe now that, okay, I think I can do this. I can transition few to TLD and the rest I leave to the third line committee. So I actually
Right.
think this was an awesome one. Maybe you want to address the issue of what you call, because I see a lot of I mean there's a trending question about TB and rifampicin. What
Yes, I
actually
wanted to address
should be
that as well.
done? Yeah, sure.
Yes. In fact, someone asked a very good question right at the beginning, and I actually did deal with it. This
Okay.
is very important, okay? Very important, okay, that super boosting and double dosing
Mm,
only applies to lopinavir ritonavir. Okay. All the other
awesome.
PRs that we have, we cannot super boost them. Why? Because they just haven't been tested. We haven't found out what works in terms of super boosting.
Mm,
So if they're on darunavir and they need TB treatment, you unfortunately can't super boost them. You can't double the dose.
mm,
Okay? It hasn't been tested. If they do test super boosting and it works, fantastic.
mm,
Then we will change our guidelines. But at this point
mm,
in time, very important. A patient who's on darunavir ritonavir and they need to go into TB treatment, you need to urgently let the third line committee know this
mm,
patient needs to go to TB treatment. What must we do? And the options are generally, if you can get hold of rifabutin. Now, rifabutin is a rifamycin, just like rifampicin, but you can use it together with darunavir ritonavir and atazanavir ritonavir.
mm,
Okay, there are some issues with dosing. They used to say give it 3 times a week, but then they found that you got breakthroughs with TB. So now you do it every day in a dose of 150 milligrams once a day. But it's because of the boosting effect, you are going to look out for side effects of rifabutin, which is usually uveitis and neutropenia.
mm,
So something you want to discuss with an expert, but if you can get hold of rifabutin, it's quite difficult to get hold of, but if you can do that. The other thing which we have done, especially in pediatrics, where you can't always get the right dose of rifabutin, is to use a non-rifamycin containing TB regimen. So using
mm.
like levofloxacin instead, but then you need a longer
Of
course.
course.
Okay. But discuss with an expert. I'm not a TB expert, and I certainly wouldn't even discuss it with me. Okay. But rifabutin or a non-rifamycin containing regimen, discuss with the third line committee, and they will guide you through this. But very important, okay, patients on atazanavir ritonavir and patients on darunavir ritonavir, if they need TB treatment, you can't double dose or super boost. So very
Mm,
good questions, and thank you for bringing that up.
mm. Leon, if the
Okay, just
pharmacist says they can get me rifabutin in a week's time, can I start on the standard doses and then switch late? I mean,
I
how
would,
long does it take for?
yeah, I wouldn't take a chance.
Yeah.
I don't
Okay.
know. I don't know the answer, to be honest. But would I take a chance? No. I mean, you're
Yeah.
compromising this patient's future. I mean, they're a third line patient. They've got nothing left after this, and you're just about to say, "Well, I'm going to put you're on the edge of a cliff. You may or may not fall off." You know, I say,
Yeah.
I would say, well, don't take a chance. You know,
Awesome. Awesome.
discuss it with the third line committee. There may be other things that you can do in the meantime, but
Yeah.
I don't know enough to say.
Yeah.
You know.
Leon, can I ask you then, practically, if you see a patient who has been on a lopinavir regimen for 18 months, not 2 years, and they have
Yes.
2 consecutive viral loads, more than 1,000, they are fully adherent. You have
Yes.
confirmation that they are fully adherent, and the CD4 count is declining slowly. Would you still wait for 2 years? How would you? I had
That's
a
a
nice
good.
discussion with
Okay.
the diplomats, and they were like, "No, but you are breaking the guidelines." But I wanted to hear your views.
Okay. So I don't know if you remember the graph I showed you last time. I can
Yes.
dig it up. Okay. It showed that the resistance in studies of resistance, the resistance basically stayed flat until
Mm,
2 years and then went up. But there were a couple of resistance
mm,
bubbles along the way.
mm,
So it's not to say
mm,
there's zero resistance, but the vast majority is not going to be resistant.
mm,
Okay. So if you've got a patient who, as you say, the CD4 count is, especially if it's dropping dangerously low,
mm,
I wouldn't wait.
mm. And
You
there's
know,
good
if it's
adherence, you know. Because I always use
do you
adherence
ever
to
know that there's
decide.
good adherence? Do you ever know that there's good adherence?
Well, I have 5 family members saying, no, we are observing, we are doing dots. And
Okay. No, I say, but yeah.
yeah, all right.
No, I think that's the role of the expert. Okay, to look at that and say the guideline says this,
Yeah.
but in this situation, the CD4 count is heading downwards. Okay, we're pretty certain that adherence is good. Yes, we will allow to do resistance tests outside of the guideline. Guidelines are a guide. Okay, it's not, we don't have to adhere to them 100%. But if you're not adhering, you need to have a good reason, and
A
obviously
reason,
someone
yes.
who knows what they're talking about. You know what I'm saying?
Awesome.
So that's the thing about guidelines. So yes, there will be situations. Same as, for example, dolutegravir. They say TLD1, right? No resistance. Okay, there are about 5 cases in the literature so far. In the third line committee, we've got 2 cases already. Okay, but often they say that they TLD1, but they're not really TLD1, because I said before, right? You go into a clinic and you're told, if you say, I've never been on ARVs before, they'll say, welcome, come inside, right? If you come into a clinic and say, I've been on ARVs before, they'll start shouting at you. So what are you going to do? Are you going to walk into, you're going to say, I've never been on ARVs. So people today are walking into clinics saying, I've never been on ARVs before. So, but those cases would need resistance testing if they're failing. So once again, it's your expert who then has to
judgment.
tease it out and say, look, let's go and look on lab track. Do we find any old viral loads? Or for example, you've got a patient comes with a CD4 of 10. Okay, but they're TLD1.
Yeah, they're in trouble.
Now, what are you going to say? Well, go back and have your viral load done in 3 months' time or 6 months' time. You may not be alive in 6 months' time. You understand? That's where the expert says, this is what the guideline says, but your expert opinion says to do, yes, I would do resistance. Same thing with a pregnant patient. TLD1 patient, CD4 is not great, and look, high viral load, and she's pregnant. What's going to say, well, see what your viral load is in 3 months' time, but then the baby's out. You've missed the boat. Okay, so I would then, as an expert, say, in that situation, yes, I would do resistance testing.
Awesome.
You understand? And that's the role of the expert is here. It's not always based on good science, but sometimes based on common sense.
Yeah, judgment, clinical judgment.
Clinical judgment, 100%.
Yeah. Nomthandazo is worried about these low viral loads. And why do patients have them, between 50 and 1,000? Maybe my question to you is that, is there a portion of this group of patients who might have significant resistance, even if the viral load doesn't cross 1,000?
Okay. All right. So we spoke about this, I think, last time.
Yes.
We spoke about low-level viremia, right? Between 50 and 1,000 is low-level viremia. Okay, and there's different causes of a low-level viremia. The one, which is the nicest one, is a blip. Pops up to 300 and then goes back down again. And that's of no consequence whatsoever. The only way you know it's a blip is by testing the viral load in 3 months' time. So today you don't know it's a blip. So Nomthandazo's got a 300 there. We don't know what it is, but you address adherence, bring them back in 3 months. If it's suppressed in 3 months, say, you know what? That was a blip. Blip is of no consequence whatsoever. Like I said, that if you take blood from a suppressed patient 5 times in a day, okay, in one of those 5 you'll find virus. Okay, because there's a bit of burst of replication every now and again. Right. So that blip means nothing, but you only know it's a blip if you repeat in 3 months' time. You repeat in 3 months' time and it's still 300, then you're going to call it low-level viremia. If you repeat in 3 months' time and it's 1,200, you know that was early failure. It was on the way up. Okay, and that, of course, you treat as treatment failure. But if it's still sitting at 300, that's low-level viremia. Now, there is good data in efavirenz regimens that patients failing a patient with low-level viremia do go on to treatment failure. And so that's why overseas, a lot of these patients will be switching them. Even here, they will switch those patients to dolutegravir. There's not that good data on dolutegravir regimens that the same applies. But our guidelines are very good because we don't sit and wait for the viral to go above 1,000 before you address adherence, right? The ABCDE is done at 50. So we are taking it seriously.
We're responding.
Just not necessarily changing the regimen. Could there be resistance in those patients? Yes. It's usually going to be maybe 1 or 2 mutations, not necessarily a bad mutation. And in some of those cases, they will, the ones who will progress will be the ones who've got resistance. The ones who don't progress are the ones who don't have resistance. But you don't know, because often at those levels, you can't do resistance testing. So it's a question of, you don't have to panic. You watch them carefully, you address A, B, C, D, E, you address adherence. If the viral load is above 200, remember that now U equals U doesn't apply anymore. U equals U
Yes.
only applies below 200.
200.
So the viral is above 200. Yes, don't panic, you can relax, but condomize, and it's not the time to start planning a pregnancy. Okay. Until you've got the viral back up again. All right.
Yeah.
But yes, so you have to approach those patients, but we don't necessarily change their regimen.
Emails. I'm so happy with Email's child, though Email is not happy. I mean, less than 20, maybe.
Where's this?
Um,
Oh, okay. Yeah, I've got it. Okay.
yeah,
Child born with HIV, now 16 years old, previously LDL,
the
now less than
machine.
20. Okay. Okay. All right. So this is a very, very good question. Because in the old days, undetectable was 400. Why? Because the labs could only get down to 400.
Yeah.
Then it dropped down to 200. Fantastic. Then it dropped down to 50. Okay. In fact, U equals U, the studies were all done with 200 because certain of the labs in the studies couldn't go down to 50. So the U equals U, although we talk about below 50, technically only it applies to below 200. Now they go below 50. Now they go below 20. Some labs, not all the labs. Okay. But some labs have gone even further. Some of the labs will tell you that if it's below 20, they'll say less than 20, or they'll say LDL. And they're different. Less than 20 means we found virus in the patient's blood. It's less than 20 copies per mole, but we found virus. They've got virus there. LDL means it's below 20 because the machine only goes down to 20, but there was no virus there. Now, whether that is a better level of undetectable than finding virus below 20 doesn't seem so. But certainly if I have a patient who's LDL properly, I'll say, look, they didn't even find any virus there. It's really great. Keep it up. But what does it mean? I don't think at this point in time, it makes a major difference. So if it's below 50, whether they found virus or not, we can call it undetectable and treat it the same. If it's above 50, look, if it's 62, I wouldn't panic. I mean, I heard someone phone, what must we do? The viral load 62. I said, you relax, relax. For sure, you're not going to wait 6 months or a year. Do it in 3 months. But 62 is close enough to 50. You know what I'm saying? You don't have to get too excited about that. So, but very good questions. And this is a 16-year-old teenager who's been suppressed their whole life. Pat them on the back, buy them an ice cream. They've done amazingly. Amazingly. Also, what I would do, remember, every patient who's been on 16 years of ARVs could possibly still be on old-fashioned ARVs. Make sure that you optimize them, change them to TLD if they're suppressed, if they're not already on TLD. Make their life as simple as possible.
Dr. Leon, from a program side, what's your expectation in terms of viral load suppression on children on TLD? What would be if I'm running a clinic like a PHC and I have 100 children on TLD, what is an acceptable suppression on TLD? Because
I'm not answering that question.
You know what I'm trying to get to.
Yeah. Now, look, the bottom line is that they should be suppressing as well as your adults are suppressing.
Yeah.
Okay. But they've got issues.
Yeah.
Okay. So it's not so easy. But should they be suppressed? I used to have a talk that I gave. It was based on an article I read many years ago, where they spoke about what the suppression rates were in adults and what they were in children, and why, and what we need to do to get there. We are basically there. We should be getting. We've got pediatric regimens. We've got great regimens. We've got once daily regimens. We've got fixed dose combinations. We should be there. It's still, we just need to get that last little mile. Okay. Okay. Adherence, disclosure, supervising regimens, and we'll get there. But is there potential to get suppression rates the same as adults? Yes, without a doubt.
Okay.
Without a doubt.
Okay.
I hope that answers your question.
Yes. No, that's awesome. Colleagues.
But they've been great questions, eh? Sure, I can't even answer half of these questions.
Yeah, all right. Paul is talking about the use of atazanavir and duranavir. We don't usually co-administer
No, we
atazanavir and
don't.
duranavir, right? So, Paul, we don't usually do that. I
No, I
don't
think
know.
he's just talking about the potential liver dysfunction with. I don't think he's talking about together, but that there is
Because
a
I see, so it
maybe.
says here, I see the use of atazanavir and duranavir concurrently
Oh, he's concurrently.
avoided.
Okay. Yeah.
Says,
So
yeah,
this is talking about the old. I mean, I've thrown my slides away on this. Okay, because we
yeah.
stopped doing it. Dual PIs. Okay. So what was dual PIs back in the old days when we didn't have darunavir?
Mm.
Okay. So they did a study of patients who were failing unboosted protease inhibitors.
Yes.
Okay. So they didn't have ritonavir with it. They were failing unboosted protease inhibitors. And then they said, okay, what do we do? They've got resistance. So let's give them two protease inhibitors. And they found they did better. But then later on, when they discovered boosting, they discovered that dual protease inhibitors was no better than a boosted PI. So there's no point in giving a dual PI anymore. You just give a boosted PI. Boosted darunavir, boosted atazanavir, whatever it is better than the unboosted. But we don't use unboosted anymore. So it's not really a discussion, but for that reason, dual PIs are not used anymore. Okay, because the study has shown there's no advantage of having two PIs over one boosted PI. But when you were using unboosted PIs, yes, there was an advantage. So in the old days, yes, it was because they were using unboosted PIs, terrible drugs, which luckily we don't use anymore. But now our boosted PIs are virtually all boosted. Sometimes atazanavir in the old days was given unboosted in a different dose. It was given 400 milligrams once a day instead of 300. But I think that's fallen away and people aren't doing that, aren't using unboosted atazanavir ritonavir. Rather go for boosted atazanavir ritonavir. So, but very good, really good questions here.
Yeah, okay, I was muted there. Okay, that's
Yeah.
awesome. Colleagues, we're gonna take the last two questions. Nomtandazo is talking about TLD and TB prophylaxis therapy, particularly isoniazid prophylaxis therapy. So the issue is with rifampicin and dolutegravir. Dr. Leon, can we give IPT with TLD without worries?
Depends what you're using.
Yeah.
Not so, Dr. Lesecha? Maybe you want
Yeah.
to talk to that.
Yeah, because he specifically said IPT, so I assumed it's INH.
So IPT is INH. So
any
INH, yes, is
issues?
not
Yeah,
a
but
problem. But
if
rifampicin could be problematic.
yeah, for HIV, okay, it's on TLD, so the patient is HIV positive. So 3HP, the current guidelines require that you have your first viral load that is suppressed before you can use high dose INH with rifampicin. But we know that the results are out for the dolphin studies, and they show that you can actually start 3HP with TLD at the same time. But our guidelines are not yet adjusted. So
Yeah.
maybe let's wait patiently on that space. But Nomtandas, if I was to answer your question directly, INH and TLD, yes, just go for it. We don't expect any significant drug interactions. Okay, the slides issues we will address. Okay, the last
Yes.
question, Celu Ukuthula. Okay, let me put it up and just see what she's saying. Boosting DTG. Patient was initiated on TB treatment while awaiting took treatment for 1 week, was booked. Results are back. Negative for TB. Is it okay to after stopping the TB treatment? All right.
Yeah, I'm not seeing.
Two
Where
issues.
is it? I'm not seeing it clearly.
So there's two issues in this scenario. Number one is that generally speaking, if you make a call to treat for TB, we generally don't like stopping. We prefer that you just continue anyway. But I think in the guidelines, if someone has completed TB treatment, you can continue the boosted DTG, I think for another 2 weeks,
2
or
weeks.
so.
Yeah.
Am I correct, Dr.
Yeah.
Leon? I hope I'm not the
Correct.
2 weeks. Yeah.
Because
yeah.
even in the patient who's got confirmed TB
Yeah.
on a full course of TB treatment, right? When
Yeah.
you stop the boosting, 2 weeks after stopping the TB treatment to allow the liver to recover. Remember, the liver
Yes.
has been induced, okay? The liver is hyperactive. It's gobbling up all drugs it can.
Mm.
So you want that to recover, and so that's why you would continue with the super boosting for an extra 2 weeks, okay, and then you could stop it.
Awesome. Colleagues, I think we have gotten to the end of this particular webinar. Dr. Leon, maybe just to highlight the Resistance Made Easy workshop, which is coming through on June 16th. Colleagues, do join us. You can attend in person in Johannesburg, or virtually you can choose. Hopefully we have a nice mix for both, because we really want to connect with you in person. But just to check with you, Dr. Leon, I know in my early days as a young, should I say, HIV clinician, I had to attend this workshop at least twice. Today I understand resistance because of this particular workshop. Is there anyone who is excluded? Who is this workshop for? I think let me ask it that
Yeah.
way. Yeah.
Very, very good question. So let me tell you about this workshop. This
Yeah.
workshop started in 2011.
Mm.
We started in 2011. And we started for pediatrics. It was just for pediatricians. And we started doing this pediatric, and it was really popular. And then we got people saying, well, why only pediatricians? I mean, what's so different about resistance mutations in adults? So we expanded it to adults as well. Okay, we did have other versions that we used for nurses as well, but there's no reason why, if people have been watching my lectures and they are comfortable with what I've been talking about, there's no reason why nurses can't come as well. But otherwise, anybody who's dealing with patients that are failing, okay. Some of the talks that I've given on your platform are very similar. So it's talking about basics of resistance. We've got a virologist who talk about specific mutations as well, Dr. Viana. We'll talk about a bit more detail about the ARV drugs, which I just touched on, the third line drugs, but we'll do much more detail. We also have a fantastic session with the Stanford database where we actually play with the mutations. I'll give you mutations, you type it in, and you generate a resistance report for your patient. So very useful from that point of view. And then we top it off with case studies at the end where we put it all together, all our knowledge together to discuss how we manage patients with complicated resistance. So
Awesome.
It's very useful. People loved coming again. I used to call them repeat offenders because it's a big information overload.
Yeah.
Even if you attend my lectures now, you need to reinforce that knowledge, and that's why I think it will be a great thing if you are able to. We really welcome you to join us on the 16th of June.
Awesome. Colleagues, I think that's all the time we have for tonight.
And sorry, I forgot to mention, don't forget the pharmacists as well.
Yes.
Pharmacists also definitely would benefit from this workshop.
Yes.
And we've had a lot of pharmacists going through it and really enjoying it.
Awesome, colleagues. So yeah, colleagues, we look forward to connecting with you in person in Johannesburg, but virtually as well. So you have both options. You'll see when you click on the link, there'll be a question, how would you like to attend in person or virtual? And then make the choice that best suits you. Dr. Leon, just to say thank you very much. May I wish you a restful evening or night with your families. Colleagues, thank you very much. Till we connect again. Blessings. Thank you.
Thanks, everyone. Good night.
If you want to hear Dr. Leon talking about low level and high level resistance, here we go for a few seconds.
No, man. Some drugs have what we call a low barrier to resistance, a low genetic barrier to resistance. So if you imagine as resistance being a wall, and you go over the wall, you get resistance. So that wall is very low, easy to go over. One mistake, one mutation, they get resistance. That's called a low genetic barrier. Others have got a high wall, a very, very high wall. It takes a long time to get over that wall. That's a high genetic barrier to resistance. So our approach differs according to which type of drugs and how long they've been. So these low genetic barrier ARVs, what are they? So 3TC, FTC, although it's not such a train smash because there are advantages to having resistant 3TC or FTC. The non-nucleosides, the viral interference or pivoring, those have got low barriers to resistance. Integrase inhibitor are not dolutegravir, but reltegravir that we used to have in old days, the low barrier.